Now I'd like to welcome Tom up to the stage. So thanks very much, Ian, and welcome, Tom. This is Dr. Tom Arkell from Swinburne University. Tom is a behavioural pharmacologist with expertise in the design and execution of clinical cannabinoid research. More broadly, he is a passionate scientist with strong creative and analytical skills and a particular interest in how drugs affect the brain and behaviour. His work to date has focused primarily on cannabis and its effects on driving and cognition. He also holds a PhD in medicine from the University of Sydney, and his talk today is titled Cannabis and Driving, Clinical Evidence and Emerging Challenges. Ladies and gentlemen, please welcome Dr. Tom Arkell.
Thank you. It sounded a bit like my resume, but maybe that's where it came from. LinkedIn profile, okay. So I've called this Clinical Evidence and Emerging Challenges, and it's really about what we do know and what we don't know about cannabis and its effects on driving. So I'm going to start with just, first of all, what we do know. Now, THC has often been found to increase this measure we call standard deviation of lateral position. I put this here because I'm going to mention it a few times today. It's essentially a measure of lane weaving. It looks at swerving and overcorrecting as well. That figure on the right there gives you some idea of what that looks like. So that top panel, that's normal driving. You see a little bit of lateral movement on the road, but really nothing to be concerned about. As your SDLP increases, your weaving motion increases further to the point that you can be crossing over the lane boundaries. And at that point, we would consider it to be quite severe. THC has often been found to reduce speed and increase headway. Now, this doesn't necessarily mean that people are driving more safely. It's more that people under the influence of cannabis tend to be aware of this, and they try and compensate for this by driving a bit more cautiously. Unlike alcohol, THC does not increase risk-taking behavior, so a very sort of different pattern of effects to what we see with alcohol. And quite importantly, these effects are highly dependent on the individual and the dose given, and they can vary really quite significantly from one person to the next. Now, I'm just going to go over a couple of recent studies that I think really get to the heart of this. This was published earlier this year, a study conducted in the US that was running over a couple of years. They had 191 regular cannabis users, so people that were using on a near daily basis. They were divided into three groups. They received either placebo, a low THC cannabis type, so 5.9% THC, or a high THC 13.4% THC cannabis type, and participants were instructed to smoke the cigarette the way you normally do at home to get high. You may take up to 10 minutes. The only condition was they had to have at least 4 inhalations. Now, what's quite interesting, if you look at the blood concentrations about 15 minutes after smoking, people with the 5.9% THC weed actually had higher blood THC concentrations than the people that received the 13.4% THC cannabis. So it just goes to show that potency isn't always everything that's going on here. Now, there were around 30 participants, so 48.3% in the placebo group that thought they had received THC. So this gives you some idea of how well the placebo was actually working in this case. Which, you know, it can be quite difficult to come up with effective placebos in studies like this where there's clear psychoactive effects. Now, what they found was that THC did impair driving at 2 out of 4 time points, so at 30 minutes and at 1 hour 30 minutes, but not at 3 hours and 30 minutes and not at 4 hours and 30 minutes. There was really no difference at all between the 5.9% and the 13.4% THC conditions. And there was also no significant difference between the three groups on the number of crashes at any of these time points. After smoking, but prior to driving, the THC group reported being significantly more impaired to drive at all time points, with the rating decreasing as those time points went on. Now, we ran a study a couple of years ago that reported really quite similar findings. So we ran this in the Netherlands at Maastricht University. This was a within-subjects crossover study involving 4 test days and 26 participants. So they came back on 4 separate occasions, and over those 4 separate occasions, they received those 4 different cannabis types you see down there at the bottom. So a THC-dominant strain, a balanced strain, a CBD-dominant strain, and a placebo strain as well. Now, the focus of this study was on-road driving performance, which we measured at 40 to 100 minutes, and then again at 240 to 300 minutes. We also looked at cognitive performance, and we also took blood samples and subjective drug effect measurements throughout the day. Now, I'm just going to talk about the driving data here. This gives you some idea of what that test setup looks like. So participants go driving in these dual-control vehicles. They're accompanied by a driving instructor who's sort of carefully monitoring what's going on and is able to take over if anything were to happen. We did have a couple of instances where he did have to come to the rescue, and luckily nothing too severe happened. And that camera thing, the tube thing rather, that you see hanging off the roof of the car, what that's doing is measuring the distance between the vehicle and the lane markings to the left of the vehicle. And with that information, you can calculate that SDLP measure that I mentioned at the start of this. So what do we find? Well, if you look at the graph on the right there, and those columns in the first part, so 40 to 100 minutes, both THC-containing cannabis types did impair driving. Now, it wasn't too severe. The level of impairment was very similar to what we would typically see in a driver with a BAC of 0.05. So that solid line there, that's a 2.4 centimeter change in SDLP, and that's exactly the change that we consistently see in drivers with a blood alcohol concentration of 0.05. Now, interestingly, impairment was actually marginally greater when CBD was combined with THC, so we didn't see any evidence that it was reducing or negating any of the impairing effects of THC. When we looked at that second drive, so from 4 to 5 hours, that impairment had largely disappeared. So there was a little bit of residual impairment, but no worse than what you would typically see in a driver with a BAC of 0.02. So certainly below what we would consider to be clinically relevant. There was also no impairment with CBD-only cannabis. Now, this probably isn't a surprise to most people, but this really does provide some of the first clinical evidence that CBD does not actually produce any driving impairment when given by itself. So now I'm going to come on to the challenges, and the first of these is that there's increasing evidence that magnitude of driving impairment does not correlate well with THC concentrations in blood or oral fluid. And this is from that first study that I presented just a moment ago, and this is plotting blood THC concentrations in relation to change in driving performance. So there on the y-axis, whether people got better or worse. And you can see here that there's essentially no relationship at all between the two variables. So the correlations are non-significant. You have plenty of cases where people had very high blood THC levels, so somewhere up around 150 nanograms per mil, but they seem to be improving. And then you also have a lot of cases where people clearly were impaired but had very low blood THC concentrations. So the authors concluded that there was no correlation between blood THC concentrations collected 15 minutes after smoking and simulated performance at 30 minutes or at any other time point, even under our highly controlled conditions. In the real world, the time from consumption to a law enforcement stop and subsequent blood collections is highly variable, and the current results reinforce that per se laws based on blood THC concentrations are not supported. Now, we found a similar thing when we looked at oral fluid concentrations in relation to driving performance a couple of years earlier. Again, here you see there's essentially no relationship between the two things. So this has been a consistent finding from a number of studies now. Challenge number 2. Duration of effects and cannabinoid pharmacokinetics vary with route of administration. So I've got 2 slides here, one looking at vaporized cannabis and then another one looking at orally administered cannabis. And I put this here to illustrate the difference in the time course of THC concentrations in the body and drug effects. So if you look on the left there, that's oral fluid THC concentrations after vaping, around 13.75 milligrams of THC, either by itself or combined with CBD. Peaks right after vaping, so around 10 minutes, that's when peak concentrations occur, and they begin to drop off very quickly after that and continue to steadily decline thereafter. But if you look at the right at how stoned people felt, you can see that at 60 minutes, participants did still feel quite stoned, and that began to drop off over those next couple of hours. But when you look at oral fluid THC, this difference becomes even much more apparent. So if you look there on the left, these are oral fluid THC concentrations after participants ate a brownie, so containing either 10, 25, or 50 milligrams of THC. And sort of like our vaporized data just a slide before, by 1 hour, they're already an order of magnitude lower than what those concentrations were immediately after eating the brownie. And they keep dropping off thereafter. But when you look at subjective drug effects at 1 hour, that's just when those effects are really starting to take hold. And over those next couple of hours, they're continuing to increase. And that really, that 2 to 3 hour window is probably when they're maximal. And by that point in time, oral fluid THC concentrations are sort of really getting down towards zero. Challenge number 3 is that we have a very limited understanding of how medicinal cannabis impacts driving. Now, pretty much all of the research to date has involved intoxicating doses of THC, generally in people that use cannabis occasionally. So the extent to which these results are really applicable to patients is something that we're not really sure of yet. Now, there's been a couple of studies that give us some clues as to this. This is a registry study, well, 2 registry studies actually with nabiximols, Sativex, And generally, they suggest very little change in driving ability in patients with multiple sclerosis after commencing medicinal cannabis treatment. So patients are generally more likely to show an improvement than a deterioration, but by far the majority of patients are really reporting no change at all in their ability to drive. We probably get some clues as well from studies that have looked at differences between occasional and heavy users. So this was conducted 10 years ago in the Netherlands as well, also on-road driving. And they looked at the effects of two different doses of dronabinol, so 10 or 20 milligrams. If you look at the left there, so this is in occasional users, those light grey columns. That 10 milligram dose of dronabinol, the level of impairment was very similar to that 0.05 BAC threshold that I mentioned earlier. With a 20 milligram dose, that was getting up towards 0.08, so a bit more significant. When you look at the heavy users, though, you see that neither that 10 nor the 20 milligram dose was sufficient to produce clinically relevant driving impairment. Now, it doesn't mean it made anyone's driving better. There was still impairment, but it didn't reach that 2.4 centimeter threshold that we would consider to be clinically relevant. So this really goes to show that frequency of use does play an important role in the extent to which cannabis does produce impairment. Now, of course, if you're a heavy user and you use twice that dose to achieve the same effect, then maybe that's negated. But on a dose-by-dose sort of case, you can see that heavy users do develop tolerance to the effects of cannabis, particularly those impairing effects. Now, we've got a couple of studies that are currently underway at Swinburne that are probing this a little bit further. The first of these is a semi-naturalistic open-label trial to investigate how long THC is detectable for in oral fluid using the SecureTech DrugWipe Twin roadside drug testing device. This is what police are currently using. 40 participants who are using a currently prescribed medicinal cannabis product. We're also looking at driving and neurocognitive performance, and we're expecting to have this completed next month, just the last couple of participants to run. So what this looks like is participants come in the morning, we do a baseline drug test, we take a separate oral fluid sample as well, so we can compare that against the roadside drug testing result afterwards, baseline driving and neurocognitive assessments, and then they go ahead and take whatever product it is they're using. So whether they're vaporizing or using an oil, it doesn't really matter. They just go ahead and take whatever they would normally take at home, and then we keep them there for the rest of the day. And we do these roadside drug tests, 4 more of them afterwards, also paired oral fluid samples, and a couple more driving and cognitive assessments. So with this, we get a nice picture of how long people are testing positive for, and how that may vary with different routes of administration. We've also got this other trial, which I'm really excited about. This is our medicinal cannabis and its effects on driving trial, MC-AID. And this is an observational trial investigating how medicinal cannabis impacts driving and neurocognitive performance over the first 12 weeks of treatment, which is potentially when impairment is likely to be greatest, if it's there at all. So with this, we've got 80 chronic pain patients. I ran the first 2 participants on Thursday last week, so this is really just getting underway now. We're also looking at driving neurocognition, so at baseline, so before participants actually start treatment for the very first time, we bring them in, we conduct a number of baseline assessments, and then they come back at monthly intervals for 3 months. They come back at 4, 8, and 12 weeks. We're also looking at oral fluid THC concentrations, other medication usage, quality of life, pain severity, and this is going to run for a couple of years. We're expecting this to be complete sometime in early 2024. We've got a number of partners that we're working with now to help us with recruitment. This probably seems like a good opportunity to stress that we're really looking for all the help we can possibly get with this. We have this really narrow window between when a prescription's authorized and then when a patient actually goes up and picks up their script from the pharmacy, often just a couple of days. So we're really looking for help from doctors and clinics with referring patients onto us. I think this is a really crucial study for everyone that's here today. So this is what our driving simulator looks like at Swinburne. It's part of a real car that's been, I suppose, chopped up and then hooked up to simulation software. We spent the last few months designing this really sort of fantastic and immersive scenario with a couple of different components. We also have this eye tracking, this ocular monitoring component to all the work we're doing. With that, we can measure things like saccades, gaze behavior, where people are looking at the road, how much they're looking at their mirrors, all sorts of things like that. So we get this really comprehensive picture of impairment during driving. I've got a couple of videos here to give you some idea of what this looks like. So this shows this car following task where participants have to try and maintain a constant gap between them and the vehicle ahead of it. And that vehicle speeds up and slows down the whole time. So participants have to constantly adjust their speed to try and maintain that consistent gap. We then have this highway driving component. So this is just essentially really boring standard highway driving. It's kind of like driving from Melbourne to Sydney, but potentially even more boring if that's possible. And really with this, it's a road tracking task. We're interested in that SDLP measure. How well can participants maintain that consistent lane positioning? We also then have this 5-choice reaction time task. Now you can't quite see everything that's going on here, but what happens is these green hexagons appear on the screen with different letters, and participants have to respond by pressing a corresponding button on the dashboard as quickly as possible. So we've got these 3 different, I suppose, components that are trying to tap into different levels of cognitive load, different levels of difficulty, to see whether that affects the SDLP measure and other aspects of driving performance. So a summary, THC may impair driving performance in a dose-dependent manner for up to around 4 hours when administered via inhalation, and probably around up to 8 hours when administered orally. The magnitude of this effect is very similar to that associated with low-level alcohol. Impairment tends to be more subtle in regular users due to tolerance and more pronounced in inexperienced users. CBD does not appear to mitigate the impairing effects of THC, contrary to popular belief, and it may even exacerbate these effects. Crash risk estimates for cannabis vary. However, best estimates suggest that a driver who is positive for cannabis is around 1.2 to 1.4 times more likely to be involved in a crash relative to a sober driver. And really crucially, we're lacking high-quality patient data around the effects of cannabis on driving, although there's several studies currently underway, as I mentioned just before. So that's it for me. Thank you very much. Please do get in touch if you have any questions at all.